introduction, purpose of study, material methodology, observation, results, discussion, conclusion. It will be, according to surgeon, abdomen is a magic box. All the time it poses new surprise to the surgeon each time. It accommodates numerable viscera and other anatomical complete disease. Abdomen constitute area full of clinical curiosity. While the clinical skill stays the main medical practice and clinical medicine is changing nowadays, increase of sophistication of imaging and diagnostic technique, the result of great diagnostic accuracy. However, first meet the patient remains much the same. Despite of advancement in the field of diagnosis, surprise never decrease. Appendix is also known as worm of the bowel or abdomen tonsil in the old medical books. In the is one of the most surgical condition of the acute appendicitis seen in the mostly in the age group of 10 to 30 years in the maximum 7% of populations. Mostly diagnosed based on the clinical history and physical examination. If the mortality rate is in non-perforated appendicitis is less than 1%, it can go to more than 5% in young elderly patients if diagnosis is late. Pre-operative diagnosis acute appendicitis sometimes challenged despite of all around improvement of medical field ultrasonography. Diagnostic score a useful easy method to help read the decision making. Delay in diagnosis lead to the complication, increase the morbidity, and overzealous diagnosis may lead to negative appendicectomy rate. Ultrasonography diagnostic technique is that improves the diagnostic accuracy of clinical outcome. What is the purpose of this study? To apply two-dimensional scoring system for evaluating the diagnostic accuracy of modified Alvarado scoring system and USG abdomen in clinical practice of acute appendicitis. The patient coming to the Department of Surgery, People's Hospital, Bhopal. Material methodology. Patient coming to Department of Surgery with the right iliac fossa pain, duration of 1 year. The study includes 60 patients. It has been evaluated by modified Alvarado scoring system, whether they have the acute appendicitis or not. All the equivocal case has been diagnosed by the USG examination. The study variable was the age group between 5 to 6 years of age, sex both male and female, tendons right lower abdomen, raised temperature, duration of pain. For selecting the patient, inclusion criteria was the both sex, male and female, age more than 5 years and less than 6 years. Presented with the lower quadrant pain, duration of pain less than 72 hours. What is the exclusion criteria for selecting the pains? Clinical signs of appendicular abscess, other problem. Patient who underwent operation for appendicectomy was excluded in this criteria. In 1988, the Alvarado diagnosed the Alvarado scoring system. And then by Cullen et al. Modified the modified Alvarado scoring system. It has been given the score: symptoms, migratory right iliac fossa pain 1, anorexia 1, nausea and vomiting 1, then sign tenderness right iliac fossa 2, rebound tenderness 1, elevated temperature 1, laboratory leukocytes 2, total score 9. This patient has been grouped in 3 groups: 9 to 7 definitely acute appendicitis, 5 to 6 scoring acute appendicitis probably, 1 to 4 acute appendicitis very unlikely. This 2D scoring system, we have combined the modified Alvarado USG finding together. What is the management plan for the treating the patient? If the patient having 1 to 4, no admission, oral antibiotic, report back if symptoms aggravated. If 5 to 6, admission, parenteral antibiotics, then observation at 12, 24 and 48 hours. 7 to 9 definitely diagnosis surgery has to be. This was the observation we have got. Out of the 60 patients, we can see that 36 is male patient and 40 is female patients. Age distribution, we can see the most of the patients come in the 16 to 38 to 32 patients, then followed by 31 to 45 years, 14 patients, then 5 to 15, 10 patients, then 46 to 60 years, 4 patients. According to modified Alvarado scoring system, number of cases out of 60, 33 is A group, that is 55%, group B 20 patients, and group C 77 patients, that is 12%. According to USG abdomen, the positive we have found in 46 out of 60, that is 76.6 Equivocal we have found in 8 patients out of 60 cases, that is 13.3%. And negative we have found in 6 patients out of 60, that is 10%. According to histopath, we have found acute appendicitis in 52, that is 86.67, necrotizing in 4 patients out of 60, that is 6%. Gangrenous 2 patients, 3.33, and normal in 2 patients. When we have compared the modified Alvarado versus USG, we have found out of 60 patients, 53 were positive and 7 were negative. If we go to USG, we have found 54 were positive and 6 were negative. When we have compared the modified Alvarado with the histopath, we have found the 53 were positive and 7 were negative. Histopath, 58 were positive and 2 were negative. When USG abdomen was compared with the histopath, the 54 were positive and 6 were negative. And the histopath 58 were positive, 2 were negative. When modified Alvarado scoring system plus USG versus compared with histopath, it is 95% positive and 5% negative. And histopath 96.66% positive and 3.33% negative. Clinical manifestation. If we go, the most of patient having 100% patient have the pain abdomen, anorexia only 73.3 patient, nausea vomiting 52%, diarrhea 6 patient, and constipation 10 patient out of 60, and burning maturation 4 patients. Constipation is more common, but diarrhea can be posterior pre-ileal patient we can see. Sign. Out of these 60 patient, we have found the 60 patient right iliac fossa tenderness, remote tenderness found in 44 patients, fever in 50 patients, guarding rigidity in 9 patients, or roving sign is 15 patients. Roving sign when we press in the left iliac fossa pain, the patient get the pain in the right iliac fossa due to the mobility of the gases which press in the cecum. Leukocyte count. Out of that 60 patient, we have seen the maximum patient having 10,000 to 14,000 count, in that is 22 patient, followed by 14,000, 18,000, that is 18 patient, then below 9,000, 14 patients, then followed above 18,000 only 4 patient, then 9,000, 10,000, 2 patients we have seen. USG, according to USG, we have seen the most of the patient having the graded tenderness. McManus point is 34 patient, followed by acute appendicitis according to USG 26 patients, then mesenteric adenitis 1 patient, renal or ureteric calculi 4 patient, ovarian cyst 1 patient, and normal we have 7 patients. Intraoperative finding of the appendix. Inflamed appendix was found in 45 patients, gangrenous in 2 patients. The perforated appendix was 4 patients, normal appendix 7 patients, twisted ovarian cyst in 2 patients. The intraoperative position of appendix, retrocecal well 41 patients, pelvic position in 14 patients, subcecal in 3 patients, pre-ileal, post-ileal 1 patient, others 1 patients. The post-operative complication, we have found the 7 patient having the wound infection at the local site, the lower respiratory tract infection 2 patients. Statistical analysis was done to determine the sensitivity, specificity of modified Alvarado scoring system and ultrasonography. The most positive negative predictive value were calculated, and histopath was considered for confirmation of the diagnosis. If you see the statistical analysis of modified Alvarado scoring system, sensitivity is 89.6 of the modified Alvarado scoring system, specificity is 50%. Positive predictive value is 98.1%, negative predictive value is 14.28%. Statistical analysis of USG abdomen, sensitivity is 91.3%, specificity is 50%. The positive predictive value is 98.14 and negative predictive value is 16.66. We come to discussion. Out of these 60 cases, out of the acute appendicitis was seen mostly in the male, prone for the acute appendicitis in the female. That 40% were female and 60% were male. Out of most of the patients found in 16-30 years group, that is 32 patients. Modified Alvarado scoring system group A having maximum 7 to 9, 32 patients. According to USG, 77 having equivocal, positive, 13 is equivocal, negative is 10%. Out of this, when I studied 2 interesting cases, I found that according to modified Alvarado scoring system, 9 patients have 9 score. USG finding was negative. Histopath was normal. Then second study was modified body scoring 4. USG finding was equal. Histopath was normal. So only modified body scoring system or USG is not independently effective for diagnosing acute appendicitis. With the modified body scoring as diagnostic tool, acute appendicitis positive 53 patient, whereas histopath 58, where confirmatory have pathology. With the USG abdomen 54 having the this acute appendicitis, which compare with the histopath only 58 patient. With the use of both USG and this histopath, USG and modified bodies 57 were the positive, and according to histopath 58 positive. Is simply to use and easy to apply in the real. Only history, clinical exam and basic laboratory investigation needed in this. Is cost effective, can be used in all setup with the basic laboratory facilities. Ultrasonography is also sensitive investigation to diagnose acute appendicitis, also help in diagnosing any other condition that mimic acute appendicitis. It can be also used to adjust the doubtful cases where diagnostic dilemma arises. When combined modified Alvarado scoring system USG can work very effectively in diagnosing acute appendicitis correctly and in reduce the number of negative appendicectomy.
Sir, please.
What is the conclusion? The modified Alvarado scoring system is a good diagnostic indicator for acute appendicitis. Sensitivity is 98.8%, and it helps in reducing the negative appendicectomy. It can work very effectively in routine practice and adjust the surgical decision making question. Acute appendicitis ineffective in children and men, but diagnostic laparoscopy may advise to minimize the unacceptable high pulse based in women. This was the reference. Thank you.
Thank you so much, Doctor.
Thank you very much, Dr. Kumar. It's very well-known topic in general in acute abdominal surgery. Does anyone have any questions from our audience? I suppose it's quite interesting to... Just a second, the microphone is coming.
You mentioned about sensitivity.
Yes, sir.
Did you find what specific test? Specific for acute appendicitis, because you mentioned sensitivity 98.8%.
Yes, sir.
I was wondering if you have checked the specificity as well.
I think it was 50% on the slides.
Yeah, 50%. Sir.
On one of the slides, there was. Can you just go back to one of those tables? And,
It is 50%. 50%, sir.
I've got.
Less than 4%, you said no need to admit the patient. We give antibiotic and send the patient, you said.
Yes, sir.
So suppose in early acute appendicitis, don't you think the antibiotic will mask the symptom? The patient already treated? Don't you think you are missing the real appendix? It's okay.
So, do you use this Alvarado score in emergency department or in general surgery department?
Sir?
You using this Alvarado score on admission of the patient in the emergency or upon admission to general surgical department?
Mostly we are using in the general surgery when they come
At
to
what
outpatient.
stage do you start calculating
Yes,
the
sir.
Alvarado score?
Yes, sir.
In general surgery department?
Yes, sir.
So suppose at that stage you're already thinking about possibility of acute appendicitis and you need to exclude it. Any other questions?
That's all.
All right. Thank you very much, Dr. Kumar.